Is there any question from the floor?
So before we take the questions, why don't we ask Dr. Wong to come up and join the panel? I think his talk was put off until the afternoon lymphoma session, but he was originally part of the panel, so let's have a full show of force up here.
I'm Dr. Bhattacharya from Calcutta. I'd like to direct my question to Professor Duri. And this is a question of using Zometa or pamidronate in myeloma patients. When I'm practicing in India, what I find is there's a huge incidence of vitamin D deficiency. So a patient comes to us with myeloma and maybe the vitamin D is suboptimal. And the moment you start Zometa or pamidronate, they become hypocalcemic. So maybe the international guidelines needs to be modified for Indian subcontinent. What would be your opinion for that?
Well, I think that I didn't touch on it in this talk, but I think that we do need to pay attention to that. I think that there are two or three aspects. Number one, vitamin D deficiency is much more common overall. It's pretty common in the States because of the widespread use of suntan lotion. But I think that now there is a recommendation to do a baseline vitamin D testing and then to supplement vitamin D with replacement of a few thousand units to get to the normal range. And so I think that you're right. I take your point. We should pay attention to that.
Because if a patient comes to you with hypercalcemia and along with vitamin D deficiency, how do you manage that patient?
I guess I'd manage the hypercalcemia first with, and go from there, yeah.
Thank you.
And I'm going to ask Dr. Coleman to come up and perhaps re-ask the question that you asked during the previous session and see what Dr. Geralt answers, because I don't think his talk fully addressed that. And I didn't want you to get away without that.
We'll rephrase the question. A patient who is good prognosis, intermediate prognosis, who's gone into a strict complete remission. And we'll leave out the molecular complete remission because that's not readily available. What do you advise that patient? First off is, do you need a transplant? And second, do you need maintenance?
So I think, the facts are that there have been 8 randomized trials looking at early versus late transplantation, or early versus no transplantation. And most of those trials showed a benefit for progression-free survival for transplant, and a couple of them showed an overall survival benefit. All of those trials are old, and they're not relevant for the type of patients we're treating today. So the second fact is that in the absence of a randomized trial, we will have to recognize that this is the type of patients that we will say, look, we cannot show you that you will benefit, but the preponderance of evidence shows that high-dose melphalan will increase the depth of your response and you will probably benefit from this. Now, the third part of this is, can we do a randomized trial looking at CR patients early versus late? The average CR duration today is approximately 4 years. By the time that trial gets done and implemented, will probably be 100 years. I don't think it's probably the most relevant question to ask myeloma patients today. I think it is reasonable to tell a myeloma patient who's achieved a CR with low and intermediate risk that the chances of that CR lasting a long period of time without a transplant is also reasonable, and they could opt to defer their transplant. And, I mean, it really is a choice. It's not a necessity.
So we need love, air, and water, but not a transplant.
Correct. Transplant's a choice. It's not a necessity. And you forgot food.
So if you might, I'd like to comment on this point because there is a study that the working group is doing right now to try to get a handle on this, where there would be information available now without waiting for 5,000 patient study. And so the question that's being asked is if a patient has had an excellent remission and then has been transplanted, some of those patients will stay in remission for many years. The question that we don't know is which patients are those. And so right now what we can do is learn a lot by looking at patients who have had a transplant and gone into a CR or maintained a CR for in excess of 5 years, which is what we're looking at. And some of those are in remission for 10 years or even 15 years. But we don't really know which patients those are that seem to particularly benefit from high-dose melphalan.
It is one thing that we could make recommendations with data, or with the lack of data, we explain the options to the patients. But oftentimes I think what I do in my practice is ask the patient to explain all the data, the rate of a secondary malignancies, the rate of a progression for survival of the period, what's the data about the CR. So the patient oftentimes, they are very knowledgeable and they can tell you their preferences.
Well, just a comment, in every other disease, the best time to do an autologous transplant is at the point of minimal disease. And so myeloma, again, is a contradiction in many areas, but that principle is likely to be true if we have effective therapy. And, your goal ultimately is to eradicate the last tumor cell, and if you hit them with your best therapy at the time of low tumor bulk, is at least the reasonable way to get there. And so again, we may need better drugs to do it, but the rationale at least should at least be consistent with the rest of medicine.
So I agree with that. The one point of difference I have with Sergio is that it may be that we cannot assess that by looking at an M component marker. Obviously, if there's no M component, how do you assess the added impact of the high-dose melphalan? And I think that that stem cell or whatever cell it is that leads to the subsequent relapse, we don't have tools to look at that right now. So that at the present time, we need to look at the outcomes to try to get a handle on it.
We're going to give Dr. Girault the last word, and then we'll close the session to let our lymphoma colleagues go.
So I want to remind everybody that of all the trials that can help us inform this question, we now have an IFM and a DFCI trial, which will look at 700 to 1,000 patients. About 400 of them will achieve a complete remission. So we will have 200 patients who will be getting transplanted versus 200 who will not. So that's going to be a very important data set to look at. And the IFM trial looking at lenalidomide maintenance, many of us thought that the CR patients were not going to benefit. And the magnitude of benefit for CR patients getting lenalidomide is actually the same as PR patients. So I think the main problem we have is that what we use to define a CR is not a very good, measurement.
All right, and with that, I'd like to thank all the speakers and the panelists, and enjoy the next lymphoma session.